looked at, which is the Beyond Belief. And we'll do a short exercise with that. So it's going to be a combination of exercises, learning that kind of stuff, and lecture today. At one point, I will go through a bunch of slides, about an hour's worth of slides. We'll take a break. We'll come back and we'll do some more sort of pair and share things, working with some scripts. And then tomorrow, what's going to happen is please be here on time at 1 o'clock. And we are going to be working with standardized patients. So we have 5 standardized patients. Nate, do you know what SPs are? They're individuals functioning in large measure as actors, right? They are taking on the character and the persona of a patient. And these cases, so this is case-based learning, these cases are pulled in large measure from real cases with some creative additions and deletions on my part. And each of you will be working inside your SGD group, and we'll split the class. So the first half of the class, the first 5 SGDs will go to 5 breakout rooms that are external to this classroom. And actually, the second group, those of you who have an SGD number which is 6 through 10, can actually show up late in class. Tomorrow. You can come at about 2 o'clock rather than 1 o'clock.
Sweet.
And then we will, Dr. DeSalle will be in here with you, with the groups 6 through 10. And I will be working with the standardized patients in the breakout rooms with groups 1 through 5. And then we'll switch. And the students who've been working with the standardized patients will come in here with Dr. DeSalle, and the second group, 5 through 10, will go out to the breakout rooms and work with the standardized patients. So each SGD group will have the opportunity to work with 5 different patients. And you're being asked to use motivational interviewing skills in your interface with these standardized patients. So today is really the opportunity that you have to sort of get something of a grip on what MI is and isn't. So that's the idea. Questions? I mean, that's a pretty broad, sketchy outline. When you come back in here to work with Dr. DeSalle, he'll have some more bells and whistles and activities for you. And in fact, you're going to be doing your second, or your third actually, your last for this semester, SGD exercise in the classroom with Dr. DeSalle, which will be linked to your work with the SPs. Okay, no questions, at least at the moment. Everybody has no idea what I just said. Okay. You're going to have fun, I think. Last year it was very well received. People really enjoyed it. Can you help me hand stuff out? So you're asked to put your student ID on here, or the last 4 of your student ID. There hopefully are enough for everybody.
So, are you going to be able to make early, or?
You can start when you get it.
I was going to say, thank you, Dr. Shah.
Thank you. You say what?
Even if you start at 1.
No, I think like to now.
1 to 2, 2
This
to
is
3,
wishful thinking. Like.
and then I'm good, thanks.
She's I have a perfect one.
I'm eating my cookies. I don't have perfect breath. I ate onions. You want to smell my perfect breath?
I'm done.
I had that. What do you mean? Wow, here. I just like the crunchy fries.
Could everyone please stop the bus? Just work on questionnaire.
Yes.
Anyone here who doesn't have one yet?
First, you get to the last thing.
Yeah.
Is it first thing? That's because it's final, so that's what it's almost finished.
Everybody have one? So, what I want you to do is, I don't know if it's too much of a pain in the neck to take out a piece of paper. The first role playing, take out a small piece of paper. You're not gonna hand it in, but I want you to write something down rather than just think of it in your head.
Oops. There you go.
Go need paper. Get a piece of paper. Okay, here's your first, hello, can I have your attention? Pass. Okay. The first role-playing exercise is this. You are not you for a moment, okay? You are one of your parents, one of your grandparents, some member of your family, you choose, and you have certain beliefs that would suggest that you are not going to really be all that adherent to a treatment plan having to do with Western prescription medicine. Okay? So write down something about that person's belief system or the way they might adjust what they're told by a doctor or a pharmacist to match better their own decisional process. Would they not pick up the medicine? Would they take some other medicine that they know from some other circumstance that they believe in more? Would they be likely to decide the diagnosis wasn't even accurate in the first place? Would they take the medication? Sometimes. Would they ask you whether or not they ought to take it? Who would they trust in that mix of circumstances? Or what would the mistrust be? I'm just asking for a sentence or two. What I'm trying to get you to do is pretend you're someone else other than who you are, and bring to bear on this whole issue of adherence and patient complexity something that you know from your own family that might intrude on the adherence that we're trying to get. Done? I'm trying to move you from an academic frame of mind to a personal one. So we're going to move back and forth between those things, between the professional hat that you're wearing and the patient hat and the personal dimension of being a human being throughout these exercises. So it's going to move you back and forth and back and forth. And I'm hoping to dislodge a little bit the idea that one is not linked to the other, because they're all linked together. So here's a personal experience from my life. My mother hated doctors. Hated doctors. And why did she hate doctors? Because in her belief system, doctors had killed her mother. She lost her mother when she was 14 years old. Her mother had to have an operation. I don't even know what the operation was. But according to her, the doctors left some of the surgical instruments inside her mother.
Okay.
You know, she herself would have been a child at that time. Who knows how clear or accurate that understanding was. Long story short, she lost her mother when she was still a young adolescent, and she never forgave them as a profession. Okay? So, you know, it takes many, many forms, but it operates in the real world, okay, for people. So, who would like to share something about what you wrote down with the rest of the class? Yes?
Sometimes people don't want to put something in the body that's not normally there.
Okay. So they think of medicine as
You think it's
kind of unnatural.
chemical.
A chemical.
They don't wanna put it in their body because it's something that, is not normally there.
Okay, good. Anyone else? Yes?
My grandma's very religious, so she believes that praying will cure her instead of taking medication.
Could you hear over here? Grandmother is very religious and she believes that prayer is what will cure her. she's certainly not alone in that. So medicine is a little beside the point, right? Yes,
Some of my friends will only go to an acupuncturist, and for treatment of any colds, strep throat, they take their kids there, and never to the left.
okay, so it's acupuncture is okay, but physical medicine, not so much? Or not at all? Okay, good. Anyone else?
You raise your hand
Yes.
higher. It's
I'm
right
not gonna
behind
say
your
who,
laptop.
but this is
No.
what I've heard from multiple people. They just want your money and they wanna make your health worse.
See? So it's a bit of a conspiracy, actually, right? The whole healthcare profession, they want your money, and a lot of things they do make you worse.
Oh, it's just when my dad visited me from Africa, he always used to complain that people take medication for everything here. Like you have a headache, you just take medication, or where you can just rest.
Okay,
So he's just like people overtake medication.
overtaking medicines, yeah, absolutely. And the idea that, give the body a chance and it will heal in a lot of situations. It isn't always a medicine situation, right? There are a lot of people who share that belief, yes.
Yeah, I know a lot of people who don't trust healthcare professionals, so a lot of their mindset will just be, I'll just take something I have at home.
Talk about convenience, right? I must have something in my medicine cabinet that will work for this. Oh, maybe my brother actually was prescribed, but it's right here. So maybe I don't need to go out of my way in order to see someone. Yes.
My dad gets really bad migraines, but he won't take medication because he doesn't want his body to get used to it.
Oh, doesn't want his body to get used to it. That's interesting. So is it a sense that the medication will somehow become addicted or habit forming? Or is it much bigger than that? Pardon?
That it won't work on his migraines, so he'll say that you're really bad.
Okay. So we have ideas about what works and doesn't work for our body and our lifestyle and our belief system. So how often do you think people bring these to the discussion with their primary care physician or their pharmacist, the community pharmacy? Not all that often, right? It really requires a certain kind of dialogue, a certain kind of trust, and very often there isn't time for it, and very often we aren't trained with the skills to enter into that kind of dialogue. So this work is really to begin to work on that a bit more. So motivational interviewing is a form of collaborative conversation. Collaborative, meaning it isn't coming from you, it's coming from you with them for strengthening a person's own motivation and commitment to change. It's person-centered, addressing common problems of ambivalence about change, and paying particular attention to the language of change, like how willing or interested or invested is this patient in doing X, Y, and Z, whatever that behavior is. One big behavior, obviously, for pharmacists is adherence, right? We know that's a big issue. What are some other behaviors that might be relevant for pharmacists? Patient behaviors. Drawing a blank?
Knowing what you're taking.
Knowing what other things they're taking. Why is that important?
Just to make sure your records are clear and make sure there's no complication with whatever else they're getting.
Okay.
Just
Okay.
in general, for their patient's safety as well, in case of some emergency situations, if they're taken to
Got it.
at least have some knowledge.
Great. Okay, you agree? What else are they taking? You want to make sure there aren't opportunities for adverse drug reactions that really have nothing to do with the prescribed medication you're dispensing at that point in time. That don't lead to an emergency department visit. Other behaviors. What about smoking? What about whether or not they believe vaccinations are helpful or not helpful? What about diet and nutrition if someone is got quite a number of comorbid conditions that are linked to obesity or being overweight? What about physical exercise? Ever heard of the idea of prescribing exercise? It's becoming more and more popular. Okay. So over the past 20 years, MI has had wide application to a variety of behavioral domains. So it started out in substance abuse. So the idea was, we decided that use and abuse of alcohol and other drugs is an unhealthy behavior. So we're going to design an interviewing skill that's going to help to motivate our patients who are using alcohol and drugs in unhealthy ways in order to change their behavior around drug taking. But it's now used in healthcare settings. Long time. There are more than 150 clinical trials, and it's well regarded as a valuable tool among healthcare providers. It runs a bit contrary to the other patient consulting strategies that you are taught in this school. I don't know what to do about that for you. You can decide whether this is helpful to you, how you integrate it with the other things. So why do we need motivational interviewing? Well, it's a limitation of our educational and self-management approaches that we assume that patients are motivated to accept the treatment recommendations we give them. Assume means maybe yes, but maybe no. So if you approach every patient consult with an understanding that maybe this patient is just getting through a business transaction, but maybe they are not really believing what you're telling them, or have not really understood what the doctor said to them, they can parrot back the answers to those three principal questions and walk away and be splendidly non-adherent. So here's another problem. So what's this a picture of on the right-hand side? Iceberg. What do we know about icebergs from the Titanic movie, if nothing else?
Large at the bottom.
The big chunk is under the water, right? You can't see it. That's the thing about icebergs, at least when we used to have them before they all started to melt. Okay, so here's the deal. Patients living in community settings experience many symptoms they do not report to clinicians. Did you know that? Can you believe it? You should believe it, right? And this phenomena is referred to as the clinical iceberg. They may come with this complaint and this collection of symptoms, but there are other symptoms they may have that are never discussed in that environment. Does that complicate the treatment? Does that complicate their taking of medicines? Potentially. So what are the implications of unexplained symptoms? Not only are there things they don't necessarily tell their clinician or their healthcare provider, there are also a wealth of things that are clinically really tough to explain. How difficult is pain? Everyone experiences pain in different ways. People may go to their doctor and complain of pain, and the doctor may not be able to figure out why, where the root cause is of that pain. A lot of pain, a lot of symptoms are connected to psychosocial stressors, are things that are very difficult to explain medically. 90% of these patients present with medically unexplained symptoms, and 2/3 of them are the only manifestation of their psychosocial problems are these unexplained symptoms. So, the medicine is not going to change the psychosocial situation for these patients. It will not pay the rent. It will not deal with the marriage that's falling apart. It will not fix the child which is not going to school, who is not going to school. Life is complicated, and stress over time, as we know, is really a problem for us health-wise. So there are other things about human behavior that fall outside the symptom, clinical diagnosis, treatment plan that are very integral to doing effective treatment and assuring good outcomes for our patients. This is just, life, okay? So pharmacists have many opportunities to talk with patients about their health behavior. Diet, exercise, smoking, alcohol use, medication adherence. So as we talk about patient-centered care, as pharmacists pharmacists become increasingly charged with being healthcare providers, human behavior has got to be integral to this patient care. You have to show you care. You have to show you're listening. You have to actually ask the right questions in a way that invites your patients to share information with you that's really going to be helpful in terms of how well the medication and the treatment plan is going to work for them. So a good adherence to prescribed medication is essential if that therapeutic benefit is to be optimized. And adherence and persistence are influenced by a whole bunch of issues. What is persistence?
Keep taking it. Keep taking the medication.
Keep sticking with it. So a big issue for non-adherence is something called lack of persistence. Meaning if we have patients who have chronic diseases who really technically are required to use these medications on an ongoing basis for a very long extended period of time, they may be adherent for a short period of time, and then they may get really tired of it, or life may intervene, or other medications may make their medication regimen too complicated, and they may fall off the adherence pattern. So persistence is the likelihood that someone will have a hard time sticking with it over an extended period of time. It's a very big issue for us. So the key aims are to shift the discussion to a patient-centered rather than a disease-focused interaction. Just think about it for a minute. So what do we have in the electronic health record?
Previous health conditions.
Previous health conditions. Do you have the diagnosis? Do you have the name of the prescription medicine? Do you have the dosage?
You can see how often they refill medication.
How often they've refilled? Okay. What else?
Prescribed.
Insurance.
I'm sorry?
Insurance.
Insurance.
They're prescribed.
Insurance about what insurance will cover for their prescription meds, right? Good. So, tell me how much of that is patient-centered, not disease-focused?
None.
How much?
None.
Not much, if any. So where's that going to come from?
The provider.
It's going to come from the provider. It's going to come from you. Or maybe it's not going to come from anyone. Maybe it's not even going to be in the mix. And guess who loses? We all lose. So, yeah, we don't have very much time. Well, compared with physicians, pharmacists are thought of as highly accessible, right? We are physically accessible. The question becomes, are we attentive to our patients? Are we available to them at an empathic level? Can we really be that critical link where so much of the current medicine configuration misses the point around human behavior and humanity and the complications of physical issues in context of our life and our lifestyles? Explores the ambivalence associated with behavior, like taking medicines. It encourages patients to express their own reasons for concern with their lifestyle behaviors and health issues, not for us to tell them. You know, you shouldn't be smoking, not good for you. You know that, right? That's not what MI does. It builds the patient's internal motivation to adopt health recommendations. Because is that more powerful than me telling them? They don't know me. It's far more powerful to hear themselves say it. Helps recognize and resolve their ambivalence about behavior change, like adherence. So pharmacists often become what are known as information dumpers. I didn't make this up. Why would that be?
Because we're at 6.
How? Okay, so it's the end of October. You're almost through, 2/3 of your first year of pharmacy school. How How much information have you been given so far? Reach on, real wide, real high, right? You spend 4 years being given an enormous amount of information so that you can go out and work professionally. You want to give that to people. It's only natural. You have a tremendous amount of expertise to share. The reality is that just giving that information to patients is often daunting, and often they are not able to be receptive either because they have low health literacy, they're busy, they don't have time, they don't understand the words you're using, or just maybe there isn't a window of opportunity for them to learn. So let me see if I can get the document camera to work. The document camera is. This is. No. I wonder if it's even plugged in. The power button doesn't seem to be lighted. That's always good, the power button before.
She said, please.
Okay. Okay, we give up. All right, back to the resident PC. Here's the deal. I will read you a story. No, I'll read you just a little bit of this and then I'll post it on Blackboard after class. Sorry, can't get the document to work. So, title of this, just posted online today, or yesterday. Counseling patients with newly diagnosed chronic conditions. Okay, just take the title. Why might that be of interest to us? We're talking about counseling, right?
Can you read the title one more time, please? Can you read the title one more time?
Sure. Counseling patients with newly diagnosed chronic conditions. Okay, so this is not, you're not counseling someone with a refill, you're counseling someone with a new prescription. But not just a new prescription, a new prescription for a newly diagnosed condition, right? Those are the pieces. So this person says the community pharmacy is often the first stop after a diagnosis of a new chronic condition. This pharmacy visit is typically made to pick up prescriptions or other self-care supplies needed to manage the condition. As the pharmacist plans to provide the necessary education and counseling, it's important to keep in mind the patient's overall readiness to receive and retain the information. Unfortunately, the patient's ability to participate fully may be diminished, as a chronic condition diagnosis can often bring on emotions that are similar to the loss experienced when dealing with death. Does it seem kind of over the top? Actually, it isn't. There is kind of a grief process
There we go.
that a diagnosis. Oh, get it to work?
Yeah.
Cool. So there's someone named Elizabeth Kubler-Ross, and let's see
Oh,
the
thank you.
document.
What do you do?
Is it up?
Yes.
Oh, kind of crooked, but it's there. Never. Is that straighter?
Other way.
Other way.
Mm.
You know, how can you operate the machine
I am
and
so good.
sort of go back
Direction.
and forth with
So
the
good.
slide?
Look at you.
My poor patience.
Okay, anyway, long story short, when someone has a new diagnosis, it is potentially the case that they are going to go through a process of anger, of denying that the diagnosis is correct in the first place. They may want to kind of bargain. Well, if I take this med, is it going to fix the problem? Is it just going to go away? They may be really sad. So these are steps that have been found to be characteristic of the grieving process when someone is dealing with the loss or the death of a loved one. And it's just to put you in mind that that teachable moment when someone has a new diagnosis is potentially really full of emotional conflict on the part of our patients. It isn't just a business transaction. Does that kind of make sense? It's just it's a thing. Whoops.
It's a thing.
So pharmacists must focus on the patient, their beliefs and attitudes. Okay, so it's good to talk, but it's better to engage. So there's a 7:38:55 rule. Great numbers, huh? You will not be asked to break this up. Anyway, 7% words, 38% tone of voice, and 55% nonverbal behavior for conducting an engaging interaction with someone. That's a lot of tone and nonverbal behavior. That means that if you are, by character, more comfortable sort of being in the far back room dispensing pills than you are out front working directly and consulting with patients, this may be difficult for you because the script is not going to be the big thing. The big thing is really going to be engaging with individuals as people. So what we know about the leaky bucket is that a lot of prescriptions don't get filled. Those that do get filled often do not get taken properly. And that's very costly. So are patients entitled to their beliefs even if they are not evidence-based? You know, our rational, logical, evidence-based science is likely to not have the legs to convince everybody that this system of medicine is the one they should be crediting. So very often people blame the patient who is thought of as difficult. So this is an article called The Difficult Medical Patient. It's estimated that somewhere between 20 and 30% of patients are thought of as quote-unquote difficult by physicians. That's a big number. That's not like 1 in every 400. That's a much bigger number. So if you think these circumstances are really rare, you might be mistaken. So what are some of the things that might make someone difficult, quote-unquote difficult?
Someone who's stubborn. Stubborn.
I'm sorry?
Someone who's stubborn.
Someone who's stubborn. Yeah, I would say. Mm-hmm. Anything else? Anything else come to mind? Yes?
Someone just might be having a bad day.
You know, it happens. Even happens to me. Yeah. So they could be coming to you. It could have nothing to do with interaction with you, but they've just got a parking ticket. They just got a speeding ticket. They just got really bad news. And guess what? You get to be on the receiving end. Yes?
Maybe a patient that's, maybe if a patient is on some kind of like sedative or like it's in pain, you know,
Yeah.
with the medication.
You bet. Yeah, they're having a bad physical experience, whether it's with medicines, post-operatively. I mean, they don't feel well. They've come to the pharmacy because they need medicine, and they really are physically not well. So that's a big one. So the angry patient. In my experience, doctors have the most difficulty with angry patients. I'm reading. Can you imagine why?
Because they don't
I mean,
understand.
you don't know whether you've caused the anger, whether they brought it with them. You're not sure if you should try and talk them out of it, talk around it, acknowledge it. So there's issues around the anxious patient. Can you imagine working with a patient? Maybe they just got a diagnosis for something. Maybe it's really worrying for them. What about the depressed or sad patient? Would they give you eye contact? Maybe not. Would they say they had any questions or concerns? Maybe not. Would they really probably benefit from an opportunity to work with you around concerns that they really need to be drawn out when there wasn't time, when they met with their doctor? Maybe so. So, the whole concept of a difficult patient is one that is going to periodically be something you'll need to think about. Respect for the patient's agenda. Patient beliefs have a significant influence on medication taking, and their beliefs are often at variance with quote-unquote the best scientific evidence, okay? So here's a yeah but dance, and I'll just let you read it. But it's an exchange between a pharmacist and a patient.
They're not listening.
Okay, how's this working? What did the pharmacist do wrong? They didn't really do anything wrong, did they? Come on, some people from the back of the room who haven't been sharing. Would you like to share? What's going on in this conversation? Why do they call it the yeah, but?
Yeah, but I don't want to do it.
What are you left with after you've counseled this patient? What's the patient left with?
Nothing.
Not much. Pharmacists made a good effort, right? They sort of talked about cover the proper way to take the medications. Perhaps your doctor will adjust things for you if it's needed. So we did this research at Federally Qualified Safety Net Clinic in East Oakland. And we wanted to look at something called patient activation. And patient activation is probably linked to motivational interviewing in some way. Patient activation is, we all talk about patient-centered care, shared decision-making, stuff like that, but it really isn't going to work unless the patient really engages in the partnership. So one of the questions we asked at the Safety Net Clinic was, how do you feel about your pharmacist? Do you trust them? Do you feel like you get good information, etc.? In large measure, everybody said, yeah, working good. So what kind of questions do you ask your pharmacist? Can't think of anything. So the federal government at one point put out an initiative called Questions Are the Answer. We really are needing to get patients to ask questions, but we need to invite those questions in ways that engender conversation. That's why it's a collaborative conversation. So patient ambivalence, this is just a list that you can't really read from a distance about drugs on the left and symptoms that they potentially can create or exacerbate when they're taken. So we all know this, that pharmaceuticals are a complicated mixed bag, and if we think of ourselves as the people who provide the medicines, patients may not always see us as the welcoming, non-judgmental person to receive information about how the stuff we gave them really isn't working for them. It's possible. So we have to give them the invitation to have that conversation. And motivational interviewing would say you have to do it quite literally. So key tasks for health behavior change. You establish the rapport. That's why the tone and the nonverbal behavior. You set the agenda. And then you look at multiple potential contributing behaviors. You usually then single out a certain behavior. You work with the patient to assess how important it is for them. and what their level of confidence is or their readiness is to change that behavior. And you explore the importance and you sort of begin to build the patient's confidence that they can do it. So you acknowledge any steps they've taken. They did go to the doctor, they did get a diagnosis, they did have the lab work done. They're now standing with you in the pharmacy, they're following through on getting the prescription filled. So they're taking a lot of initiative around taking care of their health. And so you want to explain to them that you are willing and able to partner with them as they move through this experience, which for some people can be very scary, of working on taking medications in order to improve what's wrong with them. So you're going to talk about the person's current lifestyle, explore how unhealthy behavior affects their health. You can sometimes use something called like a typical day. Well, in a typical day, when would you take the medication? Or in a typical day, what are the kinds of things that might make it difficult for you to take the medication as prescribed? That's a personal experience. You're inviting them to share with you, you might be surprised what you get. Well, I've got 3 kids, I've got to get off to school in the morning, nothing is going to happen before I do that, and I've had my first cup of coffee, whatever. But these are key pieces, because if the two of you can decide what the most appropriate, best point in time is, that individual can actually take a breath, take a pause, and take that medication, you're helping them set up a behavioral pattern connected with the prescription and the treatment plan. It's much more detailed and individual than, did your doctor tell you how to take this? Or how did your doctor tell you to take this medicine? You're going to ask them not just about the bad things, like how are you feeling, is it really bad, is it just terrible, but the not so good things and the good things. So even if someone is exercising a little bit, that's a meaningful activity that they're doing, that they're investing in themselves and their health. You want to explore their concerns, not just shut them down. And you want to help them with decision making. So if they're ambivalent, if they're like a little bit yes and a little bit no, maybe I want to quit smoking, maybe I don't. Maybe I'm going to continue to take this medicine, but it's giving me stomach ache, and it means that I'm not able to eat this anymore, and I really like eating this, and so on and so forth. So give people the opportunity to actually enter into that kind of conversation exchange. So, okay. Patient's just been diagnosed with type 2 diabetes, picking up prescribed medication. Choose a personal behavior change issue to discuss as a patient with a colleague who is acting as the pharmacist. The pharmacist is only allowed to, okay, so this is a paired chair. So turn to the person, next to you. One of you gets to be the pharmacist, the other one gets to be the patient. And in the first scenario, the pharmacist, whoever gets to be the pharmacist, is only allowed to give information and advice. This is only for people who are still awake. Okay.
Discuss patient
Diabetes.
personal behavior change issue to discuss as a patient. Like one pharmacist is only allowed to be
Okay.
I'll be the patient.
Damn it. Okay.
You can be the patient.
Now I'll be the pharmacist. So the first part is where I'm only allowed to give information advice. Okay. So, hi, my name is Samantha. So I see you're picking up a new prescription today for a particular diagnosis. I guess I just want to let you know that for your medication, it's helped to manage your glucose because you don't have enough insulin being produced in your body to monitor the amount of glucose intake. So it basically means the food that you're eating or the drinks that you're taking that have sugar, your body's unable to really break it down. So you're going to be taking this medication today to help stimulate the proper breakdown of sugar in your body, so you're not feeling symptoms of tiredness or feeling crummy inside, something like that. So it should help with your. It should help your typical day feel a little bit less stressful, and you should be feeling back to normal after maybe a week or so taking the medication. I want to ask you questions, but I can't. What else do we know? And I know this is probably a result of maybe the types of foods you're used to eating, so your doctor probably advised you to not only be on this medication, but to kind of switch up your nutrition and dieting habits. And maybe they also recommended starting to work out and implementing that into your daily lifestyle. So, I mean, we're here for you. I know the medication is something new, but it's more of a lifestyle change overall. So if there's any questions you might have, you can ask.
Time out. Okay, what kind of information and advice did you give as the pharmacist? Pardon? You did the exercise? Oh, you should go and get exercise. That was your advice? Okay. How did the patients feel about that?
Oh yeah, how did you
They
feel
say they
about
run
that?
right out through that?
You're not about that life. Not anymore.
It was difficult in their schedule, they got a little pushback. Okay, who else, what other kinds of advice did you give, or information, yes?
Maybe recommend sugar-free.
Oh, good,
What?
okay, okay. And
Says
how
she
did
couldn't
they
laugh from
take
sugar.
that? Did they say that was a great idea? She was happy with that. She was
get one.
happy, okay?
didn't
Other
get one.
forms of information and advice from the pharmacist. Let's hear from the pharmacist. You're supposed to be really good at this part. Come on. Anybody?
Okay.
Like pulling teeth.
Tomorrow too.
Okay, which of you here was the pharmacist? You were both pharmacists? Instruction.
They're talking
One of
to
you is
each other.
pharmacist,
They're not.
one of you is, yes, back here, there's somebody raised their hand, they were actually going to share some information. Hello?
Don't
Are you
look at me.
pharmacist or patient? Okay,
Here.
what kind of
I
advice?
think we were giving it to everybody.
Oh wait, you had that one already. This one.
So nice one.
Don't get left out. Don't get left out.
I should not be eating this anyways.
I bought for my mentor.
Oh yeah, those are the chocolates, huh? You bought for your mentor? Did you buy for you?
Yeah, that's the only people I bought it for. Or like the people, like
Oh,
kids
that
who
was the highlight. Just parrot back what I just said.
Nobody got chocolate. Life is sad.
Down here? Who would get? Oh, do you? Oh, I see. Wow, Twix dark chocolate, like that's medical? Very interesting. Yeah, sort of alternative medicine approach. Okay, other advice that came from the pharmacist. Okay, never mind. All right, so, part two, the pharmacist is only allowed to ask evocative questions that engage the patient on behavior, okay, and not offer advice. Did you already do this part, or are you waiting? Ready, set, go.
Oh, you want to do it?
What, you already did it?
I can be the patient.
Come on, guys.
Oh no.
The pharmacist is only allowed to ask evocative questions that engage the patient. Like, how often do you exercise?
Once a year.
I would really recommend that you try to engage in some more frequent physical activity. Not every day, maybe like once a day. You don't even have to like go and like to the gym. You can just maybe walk around for like a couple of for like 30 minutes. It doesn't
30
have to be
minutes.
straight. It doesn't have to be like straight exercise. Just walking around and for like a couple of minutes. Like maybe like 2 hours, 2 or 3 times a day.
Okay, that doesn't sound doable.
Yeah, I'm sorry?
That doesn't sound doable. I'm so busy.
So what could be a good way for you to exercise?
Maybe if I can exercise while I'm doing my 2 jobs.
What do you work?
I work at the beauty salon and McDonald's.
All right, so
That's
This
you're
time,
staying up in work.
no advice,
So that's what I'm
right?
working out.
What are you evoking?
Don't eat the
Why,
french fries.
when we say evocative, what does that mean? What are you evoking? Evocative questions that engage the patient on the behavior in question. So what was the behavior in question?
Exercise.
Pardon? Exercise, okay. Were you successful in engaging them?
Yes. I asked her how often she exercises,
Okay,
and she said once a year.
okay, once a year. Well, it's certainly bringing the topic up into the, okay. So
No,
how
I made
often
it
do you
hard.
exercise? And the patient answered
No, I
once a
did
year.
say once a year.
Okay, that's definitely an evocative question exchange about the topic of exercise. Anybody else? What did you guys,
Like,
what did you talk about here?
She just got too bad candy, so she wanted to eat her candy.
She wanted to eat her candy.
I work
Right,
out once a
and-
week. Was still
And how did you bring that topic up?
in real life.
Sugar, was the conversation about sugar intake?
Yeah, just kind of like near Halloween, so, asking her,
How does she celebrate? How much sugar in your Halloween celebration? Okay, all right. Other advice, other non-advice, evocative questions, line of questioning, here.
We actually talked about sugar intake and kind of put a curveball so that we the replacement for smoking habit.
Yeah, you get to choose, Doc. Yeah, seems like, I don't know, between sugar and smoking, right? Oh, tricky, curveball, definitely. Other behaviors, what did you guys talk about?
I asked her essentially, is this medication something going to have to get into it?
Any behaviors come up that you were concerned about, or did it look like it was smooth sailing? No detail, just like,
We're getting there.
were we? Okay,
Yeah.
all right, yeah, so the details aren't necessarily always gonna be
I can't
forthcoming
wait.
very quickly. Okay. So there are
I really
8
tried.
stages in learning MI. You guys can look back over these notes tonight when you have nothing better to do. So, overall spirit of MI, this is a lot of information in a short span of time. Patient-centered counseling skills, recognizing change talk, eliciting and strengthening change talk, rolling with sustained talk, meaning having to do with behavior change. Resistance, so if someone wants to change the subject on you, if they say, well, you may want me to do this, but don't you think it's better that I eat sugar rather than smoke cigarettes? We just gone off down some other detour that the patient has led us down. Developing a change plan, consolidating patient commitment, and switching when you become more proficient with this between MI and other consulting skills. So overall spirit of MI means that you're asking open-ended questions, you're doing this in a collaborative way rather than a prescriptive way. So it really is not prescriptive. I can't give you the 5 questions to ask, or the 3 questions, or the 2 questions. It's got to be more collaborative than that. So you're honoring the patient's autonomy. You know what autonomy is? It's basically their right to be self-directed, right? You're not gonna be able to call all the shots, you're just not. More evoking than instilling, more listening than talking, willingness to suspend that expert authoritarian rule. and explore their capacity, emphasizing their capacity to do certain things that are related to their health and their treatment plan and taking medication. So what is MI not? It's not arguing or insisting that a person has a problem and needs to change. It isn't offering direct advice or giving a solution without the patient's permission. Like, would you be interested to hear about what some of the strategies are for smoking cessation?
No.
That's a a yes/no question, but it's an invitation to know. If they say, no, not today. You've invited it, you've introduced it, they are on fair ground to say, no, actually I don't. But some may say, yeah, actually, I would have time to do that. It means not taking an expert stance, not doing most of the talking, and not tricking people. It isn't about tricking people to get them to do what you want them to do. And unfortunately, it isn't easy to learn, and it really is rather different from practice as usual, unfortunately. So, prerequisites for change: the current behavior has to be a concern or recognized as a problem. And you have to believe that you as a patient are going to be better off if you change, right? Actually, this is going to benefit me. If this is like maybe it will and maybe actually, as some people suggested with that earlier conversation around people we know in our family, maybe it's going to make me worse. So that person is unlikely to tip towards that adherence and the understanding that the medication will really be beneficial for them, unless something in that conversation with that patient allows us to explore that with them and allows them to actually say, I'm not sure about this. That's a helpful piece of exchange. Patients also have to believe that they are able to make the change, whether it's changing their exercise or their diet, or becoming more systematic about how they take medications and when they take medications. All these things are truly within people's ability, but sometimes we're the only one who is sort of sitting in what's called the catbird seat. We're the only one who is right there at that point in time and has some knowledge about what's being asked of the patient. And we're in a good position to say, I'm really hoping that this is going to work, but let's talk about ways it might be a problem or it might not work for you, right? That's an open invitation for them to say, yeah, I'm worried, I'm already taking 6 medications. That is an open invitation for you to talk about the potential confusion around polypharmacy, rather than saying, hope you're going to do great, I know you can do it, package inserts right there on the left, good luck, lovely to see you. So there's something called stages of change. You may have run into this, or you may not. So not everybody is ready to change. So there's pre-contemplation, contemplation, preparation, action, and maintenance. You guys can read this again in your spare time. And the idea is it happens along a gradient. So if we're talking about behavior, what we know is that probably 60 to 70% of health problems that we are working with in patients at this point in time are behaviorally informed, meaning they have to do with lifestyle choices. They have to do with behaviors that are in the control of people to change if they could, if they would, if they had the kind of support and information and the motivation to do it. That's a very large chunk. So the value in working with patients with this kind of framework is pretty strong. So you're at the pre-contemplation and contemplation stage, you're just sort of looking at knowledge. Then you begin to get to attitudes, potential shift for attitudes. Like, okay, well, I know enough now about what smoking can do to my body. That's the knowledge piece. Information only, we know, does almost nothing in terms of producing behavior change. So you can give people all the good information you want, and it will sit there on the shelf, or in the drawer, or in the trash bin. So at the point at which they begin to potentially really contemplate change in behavior, we're looking at the potential shift in attitude. Yeah, maybe I could, maybe I am interested, maybe this is worth my time, maybe there's some benefit in it for me. And then behavior change is the shift that happens between that attitude shift and the idea of preparing to actually take action. Well, maybe I'll reduce the number of cigarettes I smoke. Maybe I'll try the patch, et cetera, et cetera. Maintenance is obviously what's required in order to not just quit, but sustain that change in behavior. So the ingredients of readiness to change are calibrating for each of us as individuals. How important is it to me? And how confident am I that I can do it? That's another way of saying self-efficacy. How effective do I think I can be at doing it? How many times have you gone to work with an expert in some field and they say to you, you know, I'm so impressed with you as a person and your ability to do X, Y, and Z, problem solve, take the aggressive, assertive role on your own behalf, and I'm sure you can do this. Doesn't happen very often. My car mechanic never says that to me. You know, I mean, how many times do we go out and work with people in areas where we personally don't have any expertise, and we're working with someone who does, and they say to us, I have all the confidence in the world in you, that you will be able to do this, that, and the other thing. The conversation just doesn't happen enough. And so that empowerment transaction is one that I think people will really benefit from. It means I believe in you, I'm concerned about the situation you find yourself in, and I'm here to give you some tools to help you make it a success, etc. Is this kind of it? Any kind of? Okay. So what's this kid doing? I mean, where is he in this readiness to change? Have any of you ever sat on the edge of the diving board? In this position? It's tricky to get back off a diving board. So he's kind of a little forward of just sitting on the edge thinking about it. So I wouldn't think it's pre-contemplation. Is he prepared?
He's prepared with his.
So this is obviously, he's taken action, right?
He's prepared.
He's launched. But it isn't always necessarily clear. And that's another part of the dialogue in the MI interview. It's like, just how willing, able, and interested and dedicated are the patients to making
Because
the
he has
change
this,
that
no?
we're discussing
That's
with
what I would
them.
think.
So patient-centered counseling skills, OARS, is open-ended questions, affirmations, reflections, and summary statements. The open-ended questions you know about, right? You've been around that block? Yeah. So, affirmations. Affirmations are yes things rather than no things. So when someone says something to us, we affirm that they've done it. Or even if they express doubts about something about themselves, we affirm that we think they've done it. Then there's another acronym called DARN, relates to a person's desire, ability, reasons, or needs. So these are just learning devices. That's all they are. We're sort of going back over the same thing, only called by slightly different things. To recognize patient's commitment, language for behavior change, and recognize what's called sustained talk, to shift out of the status quo. So a listening and strengthening change talk, the ability to both reinforce patient's change, and your beliefs are more influenced by what you hear yourself say than what others say to you. So the deal is you're going to encourage patients to say the kinds of things we usually tell them by asking them really great questions. So you are going to be very clever in the way you ask questions, and they will be able to hear themselves say things that we want them to come away with from their interaction with us as takeaway. Like, what concerns do you have about your recent lab test results? What might you do that could improve those test results? So those, those are personalizing that interaction, helping them to think through things. So what if they say, what might you do that could improve those test values? Well, I could probably cut down on the sugar. I could probably get in some exercise, like the doc said. Ambivalence is normal, natural part of the change process. So you want to provide that safe, supportive environment. If you're told what to do, there's a good chance you will do the opposite. Remember that people want to feel in control. You're not the only one, everybody else does too. The more central or core to you the value is, the more long-lasting and pervasive the change is likely to be. And your beliefs are more influenced by what you hear than what other people say to you. And decision-making can be facilitated by the weighing of pros and cons of any choice. You can do that actively with a patient. So what are some pros and what are some cons? So here's this prescription. Here are some of the good things about this medicine. Here are some potential issues that might come up for you that we would certainly like to hear about if they do come up for you. Not just do you have any concerns or what are your concerns, but let's talk about the pros and cons in your life. Knowledge about how likely one is to incur harm or reap a benefit is an important element in deciding to change. And you need to believe there's something you can do to affect that change. We're repeating some stuff we talked about earlier. So that interaction, what we know from research is it's so powerful. You may think it's basically just a business transaction, but it isn't. It has the potential to be far, far more powerful. And so some people are more likely than others, and you're going to sort of need to gauge that. And brief interventions have the potential to produce outcomes that are quite similar to longer, more intensive ones. So even though the counseling session with a pharmacist may be relatively brief, you actually have the potential to have a very powerful impact despite the relative brevity of that consult. Okay, let's take a 5-minute, 10-minute break.
15-minute break? 5, 10, 15.
Was it from you too? Oh, I love you. I don't know about that. That's fine.
Five-star like
Maybe one thing too from the productions. Yeah, like what the first thing, anything one, fine tuning. Wait, I don't get what this like song is. It's like 5-star like hotel.
like I'm at I'm drinking and I'm trying to like see like and he says she's mad at him basically, and then this fool's just like freaking drinking at a 5-star liquor shop.
Actually, I don't get like the meaning of that stuff.
Talk about that dark chocolate, girl.
Where?
That's like my grandpa, like, so like, it's like 5,000.
My stomach's hurting.
Oh, you pregnant? I'm just kidding.
Oh, girl. If I were, no, I'm getting my period. It feels like
Lord.
cramps. Thank you, Jesus. Thank you. Everyone hasn't learned how to deliver a baby yet, so we can't do that. Can't do that.
I shouldn't be eating this. Like. I feel my eyes getting wiggly today.
Your eyes are getting
Oh
what?
my god, yes, last night with my, I don't know if you saw my Snapchat with my housemate, we went to get like Denny's at like 1 o'clock.
Dude, that's, well, you're just like studying, right?
That's like bad.
That's okay.
Stand.
Stan the man! Where are you going? Where are you going, man?
Bro, everyone's looking at your ass.
Is it? What are you not wearing underwear? Look at you. It's like Toro Idol all over again.
Stanley's not looking for you, man. Look, I'm just saying, I'm just telling you. He's just
He's looking out for you.
Yeah, what are you doing?
Oh, Jenny! I like your hair. It's cute.
I'm just kidding. I love you. I
Oh,
thought you, I was like, where are you guys? I thought you didn't come to that. You can leave. I can keep them out. It's okay. We just do that in front people.
you can sit right here.
What's up, David? What's up, Eric? Ooh, Eric.
What, Amy? No!
Eric.
Let me see.
I told you you look like a Kevin. Just change it into Kevin. What's up? Should I just call you Kevin now? Should I just call you Kevin? Should I just call you Kevin? On the low low? On the low low? What's that? Kevin! Yep, me. That's it. You never know. Nobody asked me. I just said chocolate. Oh, you did? Also, you got two? Oh, no. You got chocolate? Nobody else. I'm nice. Nobody asked me. That's it.
No. I didn't get it. That's it.
Oh, nobody don't like us. Maybe. We're helping them. We're getting them calories. They don't need it.
He didn't really fix it.
I need a sweater now.
No. Are you getting sick?
No,
No.
because to cover myself.
Oh, let me see. No, stand up.
What's happening to say?
Girl. Okay. You need to share the love. Cherish the life.
Oh my gosh, she was like,
You should cherish.
I'm just gonna say that. I'm just gonna say that, okay? Like, okay?
Cherish the life. That's unfair, man. You need to share.
No, you don't need it. You're pretty.
Oh, I like you too.
Take one, fine, Tony.
Cynthia,
Swen,
are you guys still
give me your
stuck?
sweater.
Oh, are you guys done giving out too? Or tomorrow?
No, we need to give up because they're actually still in there because a lot of people didn't
Were-
show up.
They.
Well, P2 did show up today.
Oh, okay, so it's more P2s.
Yeah, some
Okay.
people did show up.
Right. Okay. All right.
Your hair looks
Lighter and
She
thicker.
lightened it.
No, because you know when you dye your hair, every time you wash it, it lightens. It like the color picks up. So it looks like every time you see me, it's new. No, I just washed my hair. I'm just actually taking a shower. I do, but it still fades because you know how I had blonde, so it's still there. So now it's coming out as like some funky like. I know. I wanted to go punk, and the time I choose to go punk is freaking during pharmacy school. But, yeah. I actually want to cut it shorter again. I want it like I don't know. I like it's addicting. Like what's
Semi-bob?
yeah. Yeah. It's addicting.
it's a lot easier to manage.
Yeah, you started it with cutting your hair. I think you were the first.
And all the other girls were like, oh yeah.
Yeah, P2 has her hair short like this now too. Yeah, it's just easier.
I am about to give you a cheat sheet. How about that? Ooh. So, we love those, huh?
Yes.
All right. So,
Anything. Take anything.
This is a single piece of paper. It's printed on two sides. And on one side, it says a very brief introduction to motivational interviewing. And it's why pharmacists should be involved in helping patients change unhealthy behaviors. And it lists, you know, those things that are the key techniques. And then on the other side, it actually gives you some scripts, some sentences to use to get you through that process. And you may find this helpful tomorrow. When you're actually working with patients and you can't figure out what to say. I will tell you again tomorrow about this process, but it's a lot of fun. And I want you to really come into it with a no holds barred, okay, we're going to do our very best to make a success of this kind of thing. But one of you in your SGD group will have to either self-volunteer or be volunteered to function as the pharmacist, the consulting pharmacist. And then you can continue, and other members of your group will be in listening mode. And do listen, because once you get back to the classroom, You're going to be asked to assess how well these sessions went for each one of these patients individually, as a group. That's your SGD. But if you, as the consulting pharmacist, run into a quagmire, if you just feel like you are not making progress, you can give it up. Or you can ask for advice. But you signal like this, time out with your hands, and your peers can either take over, someone can jump in to be the consulting pharmacist, or you can say, what do you think I should say, and keep on. And then for each patient, you should have different, you should take one and pass them down. There's just one page. Yeah, no, just one for you and some for other people. And while you have a time out, the SP, the standardized patient, will be like an avatar. You have extras? Like an avatar in a video game. So they will no longer be sort of mentally present. Their head will go down, they will avert their gaze, and so you will be able to talk as if they were not there. You need one more?
Wow, thank you.
And each patient,
Thank you.
yeah,
You're
these
welcome.
people here don't have each patient will come with a different set of circumstances. And anybody who doesn't yet have one? We're one short? One more? Okay, does everybody have one? Okay. I just want to give you a clue that the SPs have a lot more information about who they are and what their circumstances are than you do. Because that's the way life is, right? I mean, when you work with patients, we just went over that, right? What's in the electronic health record? Well, this much. And how much about that patient and their patient's life do you know? No. Not very much. Okay, rolling with sustained talk, ability to respond to the patient's sustained talk, and dancing with patients, that's like if they're angry or if they're bullying or they need to be in control and they really don't want to talk, they don't want to engage with you, that's known as resistance, right? Because you're there in an effort to work with them effectively, and those emotional things can sometimes function as blocks. So if you're exploring ambivalence, okay, nothing so interesting as movement. What part of living with diabetes is most difficult for you? How does that make you feel? How would this situation have to change for you to feel better about it? These are examples of questions that you can use to explore ambivalence. So you have a patient who has a new diagnosis of diabetes. So, how does that make you feel? That's a very different question from, how did your doctor tell you to take this medicine? People have feelings, so ignoring those feelings is really just kind of pushing this out of the human experience of health, illness, wellness, healing, into this business transaction, which really shortchanges you in your professional life as well as the patient in their experience of trying to get better. One of the things we know about pharmacists, and don't tell anybody I told you this, I always do this. Anyway, a lot of pharmacists come out of pharmacy school and they get frustrated because they feel like they've got a mountain of learning and expertise to offer. And very often they feel like they don't really get to make good use of it. Right? So I'm saying to you, think about some of these things, because if you want to get into health and healing and patient care in a genuine way, there are things that you potentially can do in the context of your work that are going to really make that bloom and grow. And health outcomes, we know, are just going to get bigger and bigger and bigger through the course of your professional career. Developing a change plan, the ability to recognize the patient's readiness and confidence for change, and negotiation of a specific change plan. And then consolidating and blending is this whole thing about flexibly working between MI and other approaches. So here's a case. Okay. He's an 87-year-old Hispanic male. He comes in with his grandson for an initial medication consult with the clinical pharmacist. That's you. The grandson states he's generally non-adherent with his medication. Took one pill since it was prescribed 2 months ago. Love it. Great story so far. Reports minimal exercise, high salt intake. Why is the grandson there, do you think? Maybe language barrier. Good likelihood. Minimal exercise, high salt intake makes the food taste good, you know, and lives with his daughter who prepares all his meals. So the daughter's not there. The grandson is for language reasons. You have a complicating thing. You can talk to him about dietary things, but the daughter who prepares the meals isn't there. So you've got divisions, barriers, real life communication challenges, let's call them. Okay, so no known drug allergies, and those are his medications, and those are his vitals. So what questions would you ask, and what would you do for this patient? And if this were on an exam, what would you do? What do you want to know? Pardon? Lifestyle.
What does the day-to-day look like?
So the grandson is reporting he's non-adherent. Do you want to know why?
Yeah.
How do you ask? I'm sorry? How does this medication make you feel? You like it? It's a good place to start. Do you have your hand up? Okay, sure. Are there things that have come in the way of you taking the medication? So you have the advantage of having the grandson there who is disclosing information to you that if it were just your patient, you might actually not even know at this stage about the non-adherence. But that at least has been disclosed. So that's very helpful for you to know. It means, what does it mean in terms of lab results? Is this guy likely to be at the benchmark for where he needs to be in terms of his clinical labs? Probably not, right? He took one pill. Hello? Okay. So is it time to get upset with him?
No.
So how do you express your concern? What do you know about high blood pressure, no medication, person of advanced years, yes.
Maybe ask the patient if they know what the medication is for and how it can help them.
Right. So the salt in the diet, the high blood pressure, the decision whether active or passive not to take the medicine. So here's a point. Active or passive, what are some complications for, let's say he's an elderly person in an extended family living situation, okay? is he the one responsible for taking his medicines? We don't know. Would you agree? He may not. Would the grandson be able to tell us? Maybe so. So, do we automatically assume that he has decided not to take the medicine? You don't know. What if it's the daughter who is a stay-at-home mom, prepares the meals, and really in large measure is the caretaker for her dad? But she isn't there. The grandson would be able to tell you, in the family, on a daily basis, what does daily life look like? You know, how would your grandpa be getting his pill and his medication? How do we work with your family around getting better adherence to the treatment plan, because it's really important. Does the grandson know about high blood pressure and medicine? Well, we don't know how old the grandson is, but
He's young.
we have to assume that maybe he doesn't, or certainly we have to assume we don't know if he does or he doesn't. So this is always an issue. When we're doing a patient consult, sometimes we need to be speaking with a caretaker, or we need to be speaking through a family member who can translate linguistically, right? So that's a big chunk of making sure that whatever we're concerned about gets conveyed accurately to the person who needs the information. In this family constellation, we don't have enough information to know exactly what that is. So you need to ask those questions. You agree? Otherwise, you're guessing. If you tell the grandson, let's say the grandson is 16. Are we sure he's going to take that message faithfully back to his mother? And that loop is going to go through? You can't be sure. So you have to figure out what you need to know in order to get the information that's needed for that patient to achieve the result that you need. So the non-adherent behavior is just the beginning of the puzzle in this situation. And you have to go, okay, what do I need to ask? And who do I need to ask it? And how can I work effectively with this patient and this patient's family to achieve a better outcome? So roll with resistance. This is the reads, it's, anyway, darn, reads, blah, 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 reads. Roll with resistance, express empathy, avoid argumentation, develop discrepancy, and support self-efficacy. So Dr. DeSalle says he talked with you about empathy when he worked with you the last time. You guys remember?
Very briefly.
So anybody have some ideas about the difference between sympathy and empathy? They both have that peppy thing going on. Wow, you guys, come on. Yeah.
Empathy is feeling with someone, whereas sympathy is like feeling bad for them.
So let's say someone says, I am in so much pain, and this pain medication isn't helping me. So what's a sympathy statement?
I'm sorry you feel that way.
I'm sorry you feel that way. You agree? Does that sound like a sympathy statement? Hello?
Can't help
Are you
it.
listening? You think that's a sympathy statement? Yeah? So can you do an empathy statement? You would, or you try to, or you would voice as if you could. That's got to be really hard. Yeah. You want to endorse the fact that that person feels really frustrated, that in all likelihood they're having a hard time sleeping and getting the rest that they need because of the persistent pain. They're trying, but for whatever mix of reasons, that medication regimen is not working for them, and you want to acknowledge that. You want to say you hear them, you feel for them, and you want to be of help to the extent that you can. Patient, I'm sick and tired of everyone, including my doctor, getting on my case and treating me like a child. May I offer you some suggestions on how you can lower your blood pressure now that you're being angry at me? So, what is that pharmacist doing?
It's not listening.
First of all, he said avoiding the argument. Yeah, let me just step over here now. All right, but that's true. I would say that is not. But they're asking the patient if they can do something. Next, there's an invitation. It's question mark, right? May I offer you, rather than I'm going to tell you something. Right? That's a different beginning to that conversation. Look, I get the point about exercise. I enjoy hiking, but making the time for it's a really big problem in my life. So just give me the meds and I'll be on my way. Oh, I would guess you will get variations on this more than a few times. Do you think? I think. Pharmacist, it sounds like you've given exercising some serious thought. That's the acknowledgement, right? The positive sort of, oh, well, you mentioned hiking. So, that's cool. That's a very good thing. Could you tell me more about ideas you've had that could work more exercise into your daily routine? So that's the collaborative exchange. You've acknowledged something positive that the patient is actually kind of buried. Look, I get the point. So they start out with a kind of angry, resistant, pushback message. But embedded in what they say is something you really would like them to pay more attention to, which is the exercise. So rather than going, you know, I think you really need to get more exercise, which is the advice piece, right? You're picking up on them saying they enjoy hiking. You go, that sounds really good. Let's talk about ways that maybe you could build that out. Empathy, the provider's ability, as we talked about, to enter the patient's phenomenal world. We won't go into what phenomenology is, but look it up, it's a lot of fun. As if it were your own. Feel with the patient to understand the patient's perspective. To sympathize is to feel for the patient, empathize is to feel with them. So high levels of empathy are associated with positive patient outcomes. It's the key to expressing empathy is through what we call reflective listening. Reflective listening is, to some extent, saying back to individuals what they've said to you, but with another piece of it, which is implying, communicating that you hear them, that you have indeed heard them. Another term for this is attentive listening. So rather than or a head nod, you're actually using their terms, their expression, using pieces of what they've said, and bringing it back into the conversation so that they can continue that thought or that idea. So nonverbal ways of expressing empathy on the left, warm tone with your voice, direct eye contact, genuinely attentive, leaning a bit towards them, inclining your body a bit towards them with an open body stance, and nodding when listening. Verbal, this must have been very difficult for you when you experienced these side effects. Sounds like an unpleasant side effect has been awful for you. I mean, you may be thinking it, but very often you won't say it. So in this counseling style, you would say it. The person feels validated. It's a pretty important part of the trust relationship. So resistance may take many forms: direct argumentation. Consider why a patient may be argumentative or expressing frustration. It's not a personal attack and is not related to the pharmacist, often patient's way of communicating anxiety. Do you agree? How many times have you been in an encounter with someone, or even yourself, you're just really anxious or worried about something, and it comes out as a kind of different emotional tone? with people who are totally unrelated to what created the anxiety in the first place. So the emotional impact requires that you begin to read a patient's expressions, and aware that patients diagnosed with a new condition are likely to be experiencing some of these feelings because they've lost some control over their life. This is a very, very real thing. If you ever read articles that have been written about physicians who have become patients, who at some point in their professional careers are diagnosed with something that requires that they go into extensive health care, cancer, et cetera, it is a revelation for them. They say, who knew it was like this on the receiving end? This is terrible. So, that experience can be a very profound one for healthcare providers. Very often we are always in the giving, in the doing, in the expert role, but on the receiving end, it is not such a fine and dandy experience. So reflective listening involves paraphrasing the patient's comments. I get the sense you're wanting to change but are concerned about gaining weight. That would be something that might come up around smoking cessation, right? Very often people are worried about quitting smoking because they think they will gain weight. It seems there's a lot of pressure for you to change, but you're not sure you can do it because you've tried before. What have you tried before? So even if what the patient is saying is, look, I've tried, it hasn't worked, forget it. You can come back with some comment about, what exactly have you tried before? Let's talk about things that you might still want to try. So types of reflection, you can look at this again in your spare time. Repeating, rephrasing, empathic reflection, reframing. Some of these are communication tools in the realm of psychology, but they're very, very useful. Reflect what the patient or the client has said in an exaggerated way because this may elicit the other side of the patient's ambivalence. So it sounds like you really don't care at all about losing weight. That's probably an exaggeration of whatever the patient just said to you, but maybe it will trigger them saying, no, that's not exactly what I meant. And that gives you the opportunity to sort of revisit it. What might make it workable for you to begin to think about ways you might lose weight? Conversationally, there's no way to sort of pre-script this and write down, crib sheet notes for yourself. But over time, as you begin to work with patients, these kinds of devices will become more comfortable for you. And you will learn that they're very, very productive. Things that previously might have been very truncated, far more than just shifting from closed-ended to open-ended questions, will open up the area of human experience to you in these consults and give you a window into ways to more effectively work with your patients, and it's a much more satisfying interaction. So you'll see the patient's statement on the left paired with the provider response on the right, and this is called reflection in action. So I don't want to take my medication. You don't want to take your medication. That's not to transform, because that's pretty straight. I want to take my medication, but I have trouble fitting it into my day. So the response is, you want to take it, but you have trouble fitting it into your day. Instead, it's taking your medication is important to you. Well, all the provider did was they picked the first part of that sentence and decided to emphasize that. You probably never had to deal with anything like this. Okay, so what's that patient saying? This is my experience. I'll bet you haven't had any experience like that. And so the provider says, it's hard to imagine how I could possibly understand. You may follow that by saying, would you be willing to help me understand? or how can I better understand? So it opens the opportunity that this patient feels misunderstood or poorly understood. He feels like he or she feels like there's no real way to relate to you, and that maybe that's the reason to shut the conversation down. I know that not taking medication is bad for my asthma. You're worried about your asthma getting worse. So they've transformed it a bit and given it back to the patient, reflective listening, and it gives the patient an opportunity to take it from there. Okay. Summarizing is important at the end. Shall we quickly go over what we talked about? What are our goals? What are plans to achieve those goals? Or what are your next steps? Here's some examples of affirmations. Developing discrepancy. So, anybody familiar with cognitive dissonance, with that term? Okay. So the idea between, do you know what dissonance is? Do you know what dissonance is musically? It's the antithesis of harmony, right? Dissonant sounds are ones that kind of clash. So cognitive dissonance is something cognitive that clashes. And often it's a clash between what we do and what we say. So, do as I say, not as I do. You know that one? So cognitive dissonance is believed to be a kind of an uncomfortable tension between the things we sometimes do and what we say we value or believe in. So let's say someone is, really gung-ho for exercise, but they just really can't quite get to it. So that creates a kind of uncomfortable tension in their belief system between their values. Sometimes what people do is they bring their values more in line with their behavior to reduce the discomfort. So you can actually actively play with this discrepancy to get closer to get a patient's behavior closer to their values. So they may say, I really want to be healthy, and I really want to make sure that I'm here to see my grandson graduate from high school, and so on and so forth. But yeah, I really don't want to take these medications. Yes, but if you take the medications, you actually have a much better chance of still being alive in time at the time your grandson graduates from high school. So you're working to bring the behavior in line with the stated values. So it's a device that you can use. You want to encourage self-efficacy, expressing belief in the patient's personal strengths, and very important in maintaining self-care and promoting medication adherence. And that's the end of that. So, okay, here is the next thing. Pair and share. I have enough for every other person. So 2 people to a group. You actually get to read the script. You don't need to make it up. So this is 2 consultations. Don't flip it over till you've done side 1. Consultation 1, on the back, consultation 2. And here's the deal. One of you is the pharmacist, and one of you is the patient, and then for consult 2, you switch, and you just read them. And then the discussion is, how did these 2 make you feel? Because one is done in the context of MI, and the other one, the first one is not, and the second one is. And it's just like, how'd that feel? Okay, so rather than just making up the script, you actually have it printed out for you. Who are you going to work with? Huh? Oh, every other person, I don't know.
Are you going to the review session?
You guys treat me out.
Oh, my God. That's not so complicated. We may run out of Another one here? You're okay?
So bad.
I don't know.
I'm tired.
Did you say for Raja, should we have to know all of the STD?
Stop. Do you need another one in this one?
Yeah, but like this information, I'm pretty sure you already know something.
Are you okay?
Yeah.
Are you rested? Are you better now? You get to be the patient.
Okay.
She's really concerned about you. Are you a smoker?
Well,
You make your voice sound raspy. You make your voice sound raspy like you are a smoker.
today.
No! How much do you smoke each day?
Oh, okay. Oh, I'm sorry. Yeah. Well, some, yeah.
How much do you smoke each day?
About 15 to my cigarettes.
With that chest, I must tell you, it's going to get worse if you smoke like this.
I know, but see, it helps with the stress. If you knew what I go through with that truck and the long road, it's enough to get.
So dramatic. But if you carry on like this, you might lose even more time at work.
Yes, I'm getting back to see.
Well, we got some good aids for quitting if you're interested.
Yes, thanks. I'll give it some time. Thank you, Doctor.
Oh, thank you. I'm not a doctor, but thank you. Oh, yeah, we are.
Yes, your doctor in pharmacy, girl. Get it right. Get it right. Cheers.
It's so...
Cheers. Get the
You gotta get that raspy. That's going on. That's COPD. Oh. We just heard the word whispered, and it sounded like your voice. That's why we both were like... Now I'm out. I don't know what's going on. I don't take sides at this point. Are we supposed to do the second side? Or am I supposed to?
Yeah.
Okay, so I'm the patient now?
What's the difference in concentration?
Oh, okay. Your turn.
Would you mind if we talk about your smoking? How do you feel? How do you really feel about it?
I'm trying to cut it, but I can't say it's easy with my job. You know, it's really stressful trying to change.
It's not easy for you yet. You would like to smoke less.
Oh, if I could, definitely. But I know it's not good for my chest first time.
You can. Are you okay there?
I'm good. It's smoky.
You can feel the effect for yourself, and it's not pleasant.
I know. Whoa. That's right, but it's such a stress reliever. It's hard to let go.
It's difficult for you to imagine me without smoking.
Yes, that's exactly right. You got it.
Usually this doctor is suck. I don't want to give you a lecture or hassle you about this, but I'm wondering what would be helpful for you.
You just don't know.
Tell me deep down, how important is this for you right now?
I'm sick. I'm tired. And the smoking wears me down. It was candy. Hurts my throat.
This person is like, I don't know, like, if you need help, I ain't gonna force you.
Go to a doctor. That's
Go to a doctor.
That's PCP, man. Like, you can take some patches. I'm giving some nicotine gum, but that's pretty much it.
This pharmacy is like, oh, okay.
Okay. Well, so how does that? No, I'm not a psychologist. How does that make you feel?
How does that make you feel? He was a musical. People are gonna be cracking up. Okay, I was like, because the phone is recording, okay? And I was like,
Did you get through consult 1 and 2?
okay, you're gonna hear me.
You're gonna hear her.
Who wants to tell everybody how that worked? What's the difference? Come on, somebody who hasn't spoken before. I need to take Dr. Yoshizuka's technique and call
Oh, we
names.
talked already. I didn't raise my hand, but I talked.
Yes.
Well, when do you kind of get the patient to admit there is an actual issue rather than just telling it to them? That way they are more like psychologically aware of it.
You agree? You hear what he
Looks
said?
different.
Say it loud.
My president.
President.
You get the patient to basically admit that there's an actual issue, or at least allow them to be more thoughtful about it rather than just telling them the issue.
So that's a better thing based on the things we've been talking about, right? That's probably more productive to get the patient to say it rather than you just telling them. Anything else that came up in the difference between consult 1 and 2? Yeah.
It feels like consult 1 is more empathizing more with the patient than consult 2.
Consult 1 is doing what?
It's more empathizing
Empathizing.
with the patient rather than the
Where the pharmacist says, I must tell you, it's going to get worse if you smoke like this. You think that sounds empathic?
I mean, is that for consult 1?
Yeah. But if you carry on like this, you might lose even more time at work. I mean, there's a lot of, warnings. I don't know. Do other people agree? No? What's your evidence? Come on.
But then this one wasn't even.
Why do you say?
The pharmacist was meeting with the patient and starting what he said was
Okay.
Validation.
More validation.
Feels like
People
he's
agree?
listening.
More validation in 2? Rather than 1, maybe? Any other differences that came up in your experience with this group?
So between 1 and 2,
Yeah.
the first one sounds more authoritative, it's like them telling them stuff. 2, it's more like a conversation between two people, and they're just trying to discuss.
Right. Can you imagine yourself doing 2? Or is this one sound a lot more familiar?
First one sounds a lot more familiar.
Yeah. First one is a lot more familiar based on kind of more traditional, we'll call it traditional pharmacy consult strategies. So that's tricky. Don't know what to do about that. But I mean, yeah. You are very often kind of encouraged to take the part of the expert, right? And to be the one who is telling the patient what they need to do, rather rather than asking the patient what they are able and willing to do, or what they are concerned they may or may not be able to do, or what their concerns are, or what you want them to share with you to ensure that they have a good outcome. That is an exchange. That's a dialogue. Okay. All right. Thanks for playing along. Let's go see how this goes. So here's a case. It's in the second PowerPoint that I loaded on the Blackboard, so you have the slides. It's just, I think, called motivational interviewing, whatever. GH, 58-year-old man, type 2 diabetes and hypertension, resistant to many changes that will affect his outcomes, comprehensive disease management encounter, and his pharmacists include medication therapy management, MTM, other lifestyle changes to optimize disease outcomes. So far, good, right? Good enough. Each of the following statements by GH brainstorm a few pharmacist responses most consistent with MI principles. Okay. I know I need it, but I don't like the idea of having to take another drug every day. Okay, so, you know, he's not alone. A lot of people do not really want to take medications, and if it's one among a whole bunch that he's already taking, even more so, like, enough, don't want to take anymore. Which of the following responses from the pharmacist would be consistent with the spirit of MI? Got 4 choices.
Do you understand why it's necessary?
Who votes for number 1? It's a good thing you can afford to take another medicine every day. Your votes. We had 1 vote for number 1. Okay. Do you understand why this is necessary?
No.
Good choice.
I think so. I was asking a
What if
question.
the response is yes?
Then no.
You've asked a closed-ended question, and that could be the end of that conversation. So, you don't like having to depend on taking medicine. That's a reflective statement, right? That's pretty consistent with what the patient just said. Well, it's really your choice. Been good talking to you. That'll be $12.35. Goodbye.
Goodbye.
Okay. So, that reflective statement on 3 seems to be the one that got the most head nods. I'm trying to read your, body language. Okay. Raising hands doesn't seem to work. We'll try body language. I never used to have to take so much medicine. I don't like getting old. Oh. You could just go, oh. That's not one of the choices.
You're getting old anyways, honey.
But that would be really sweet. Okay, even young people have to take drugs.
It's true. It's true.
Growing older has been difficult for you to accept. You're healthy otherwise. What concerns you the most about this medicine?
The last one.
It's a little tricky.
Having to take so much medicine.
I think one in 4.
The worst one.
The fourth. The
I'll
fourth.
say 1 and I'll
What's the
say
worst
4.
one?
You say both too.
I'll say 1 and 4.
Okay, anybody want to suggest what they think the best one is? I'm not entirely sure there is an absolute standout correct one here, but it in part depends on why you defend your choice.
I'll say 1 and 4.
1 and 4?
Yeah, I'll say 1 and then I'll say 4.
What concerns you the most about this medicine? And even young people have to take drugs. Okay. I'm not sure where even young people have to take drugs goes in your conversation if you're trying to do a conversational dance with someone. Yes?
I mean, I think 2 is good because it's like validation, reflective, but it could also lead to a different conversation.
Yeah.
Like
I
non-medicated.
kind of like that response. Anybody else like that response? Yes?
Well, I disagree. I think number 2 is kind of patronizing. It's like, growing older and
So you are getting older.
So it depends on tone.
Number 4 is best?
Yeah.
Yeah.
I'd say number 4 makes sense. to
That's
me.
interesting. So you think number 2, growing older has been difficult for you to accept this kind of patronage? Yeah, like the next sentence is get over it. Okay. Yeah, well, you can see that, you know, a lot of times, even when you've got script options, it's not so clear. You have to try this out. Okay, I'll take the medicine. I just don't like that I have to take it to be okay. Okay. You do need to take it. What would have to happen for you to be okay with taking the medicine? 2, I understand. It's for your own good, though. That's a great one. Always keep that one handy, right? Everything I'm telling you is for your own good. No. 3, you really do need to take the medicine each day. Or 4, I believe that taking the medicine is the best decision for controlling your blood pressure.
4.
4?
4.
Or can you not say I
I
believe?
believe.
I don't.
Oh, 3.
I hear rumors.
I said 3.
Okay, who votes for 1?
You do need to take it. What would happen?
Okay. 2, I understand it's for your own good, though. Not altogether. 3, you really do need to take the medicine each day. That's for the
Yeah.
white coat expert. Okay, I believe that taking medicine is the best decision. You know, yeah, it's tough. You do want to keep the conversation going, right? You do want to give them, the patient, the opening, yeah.
I would combine 4 and 1. I would make the whole statement from 4 and then follow it with the last part of 1.
Oh, well, that's creative. Yeah, no, I mean, I think there's some benefit to that, absolutely. You're endorsing what's been said in the treatment plan, but you're also asking them what would have to happen for you to be okay. Because you really want to continue. This patient is saying, I don't like it, you know. And so that to me is a bit of a red flag around, uh-oh, this person may not be very adherent in taking these meds. Think about it. I know I need to exercise also, but 3 days a week after work seems like a bit much, especially 30 minutes of walking each time. I'm exhausted when I get home. Okay, pharmacist's response is most consistent with the spirit of MI. I think you'll find it really isn't too hard to incorporate into your daily routine. I do it. No, definitely doesn't say that. Being tired is a barrier for you to exercise, which kind of reflects what they've said. Maybe you won't feel so tired if you try to exercise. Or could you try to exercise on 2 days a week?
That's not bad.
So you're listening, right? They've said 3 days a week is just really over the top, thank you very much. So you
try
come back
to.
and say, well, okay, how about you? Again, you're answering their definitive statement, which contains a lot of resistance and a lot of pushback. It's kind of like, you know, basically, I would say this patient is saying, take out the content, and the tone of what this patient's saying is, you really don't get my life. And you're asking me to do things that really don't fit. So get a grip. And so the opportunity here is, okay, let's do this dance with resistance. Roll with resistance and say, you may also acknowledge what they've said. So again, as was suggested, you may want to do a combination of 2 and 4. Because 2 is kind of a reflective statement. I hear you saying exercise is just really, you know, tough for you to work into your schedule. So would it be possible to try to exercise a bit less, maybe 2 days a week? Is that a possibility? So it isn't one or the other necessarily, but you don't want to shut it down, and you don't want to be one who is ending it all on a note of, let me tell you what you need to do. That really isn't I'm just not willing to do this after work for 4 days a week right now. Is that your final decision?
It's like deal or no deal.
Oh, I love it. Are you really reconsider? What are you willing to do right now? Because he ends his sentence by saying, right now. Or you could also say, well, if you're not willing to do it right now, what about next week? This really
She's
could
cracking
help
herself
both
up.
your GM and your high blood pressure. So,
4.
you know, you have to look at expressions of concern that are collaborative, that are empathic, that are reflective, that show that you are listening to what people are saying to you, that you're following not just the content and the words of what they're saying, but also the tone. And you're acknowledging them. Okay, so this is some stuff about methods for eliciting change talk. I'm not gonna, you can read it at your leisure. You can also use something called an importance ruler. Well, how important is it for you? How high of a priority is it for you? So again, weighing the balance of, well, the doctor says I should exercise more, but I don't really have time, and I'm so exhausted when I get home. And so how important is it for you to maybe be able to reduce the dosage of your medication? Because potentially, if you exercise more, we could be able to do that. So that may not be a kind of calibration that patients are going to know about, but you would. So the relative value and merits of behavioral choices with medication therapy are also something that you have to begin to think about in terms of integrating patient-centered care into what you do with counseling. If you do change, what do you hope might be different in the future? So you can look forward, you can look back on a daily basis. What does life look like? These kinds of things that put the patient's life experience in the center of the conversation. You're not pre-manufacturing, these short questions. So we don't have really time for this. Everybody's kind of drawn out here at the end of the afternoon. But here's the deal, practice activity. Think about it, don't actually do it, I guess, but what is one aspect of your current lifestyle, you, that if you made an improvement would give you the greatest return? So, fewer energy drinks, more sleep,
Stop going to sleep.
less school, lower
Yeah.
financial debt,
Stop procrastinating.
whatever.
Actually, get on that.
And then, how might your life be different if you made this change? If nothing changes, what's at stake? If you were to decide one day to make a change in this part of your life, how do you think you might go about doing it? And then, if you wanted to make that kind of change, once you identified whatever this thing is, you say, what's the next step? Or where does that lead me? Am I in a position in terms of my own abilities and what I know about my life to actually do something, to take the next action step? How confident are you that you can make that change? So these are the kinds of things, again, moving back and forth between the imagined patient, you as the pharmacist, you as the patient, a family member who has certain beliefs and approaches and strategies around health and medicine taking, back to you, like, okay, I have choices in my life. I have certain things that in my life I could possibly change that might make an improvement, and what is the one that I would choose here if I were looking for the improvement that might bring the greatest return to me, given my value system, given what I'm all about right now. And then this is how you have the conversation with yourself about, so what? Am I just sitting here sort of mushing thoughts together, or are there certain things I'm going to do? So there's another role play exercise. That's kind of what we did. That's the consult 1 and 2. We already did this. And then the questions, did it work? Why or why not? And that's 2. And here's some practice lab scenarios. Again, you can read these rather than do them. What I wanted to do was have you pick 3 of these 9 bullet points and figure out how you would empathize. You can play with this with other students when you're studying. What open-ended questions might you ask, and what type of reflection would you use to reflect what these patients are saying, and how would you elicit change talk? So these are all opportunities for you to practice some of this. And here are some video segments that you can watch that are with and without MI. And I think we may post another video clip.
Can you send me a photo
I
of
don't
the
know.
paper?
We have another one, but I'm not sure if it's posted on Blackboard. It's not yet. So tomorrow, if you're in SGD group, the end.
Oh, yeah.
If you're in SGD group 1 through 5, be here at 1 o'clock with bells on. If you are in SGD group 6 through 10, you may come at, is that
2.
right? 2, yeah. And what's going to happen is that the first group, groups 1 through 5, may be able to leave a little bit early, depending on how the work goes with Dr. Cassell. So, the second half of the group, 5 through 6 through 10, will come a little bit later. The first half of the group may leave a little bit earlier. So we have to do that because there's so many of us, and there are 5 standardized patients. Yes.
Because we're working with a standardized patient, do we need to dress professionally or with our white coats?
Okay, the question
I don't-
was, hello, because we're working with standardized patients, do we need to dress professionally, wear white coats? I didn't require that last year.
Okay.
I think it's okay if you, I kind of need to make a blanket statement. Because it's MI and because this is kind of a little on the theatrical side, I think we're not going to do that.
Okay.
Yeah.
Thank
But
you.
thank you for asking. That's a good point. Any other questions about tomorrow? So there will not be a lecture, but you have to come and you have to participate in the session with Dr. DeSalle because you're going to be doing this group clinical self-assessment on how you work with the patients. And that's going to be the score for your third SGD for the course. All right. Oh, and another thing, sorry, I'll say this again tomorrow, but because we have these split sessions, it can get confused. I'm going to put a box out in front of my office. My office is in room 106. So you're going to have another piece of work to do at the very end, but you don't need to do it while you're sitting in class tomorrow. So you can drop it off when we get it done into that box by Friday.
Something separate, another assignment.
What do we have to put in the box?
The assignment, you have to turn it in by paper.
Thank you. You've been terrific. Yes.
Like later on.